So I'll be speaking on aesthetic consultation decoded. Now, facial aesthetics and beauty standards vary across society, cultures, and over time. Thus, an individual contemplating a cosmetic procedure may have at times several ideals in mind. Working with these expectations can be challenging and calls for an organized approach. Therefore, there has to be certain steps in the basic aesthetic evaluation, starting with relevant patient history and systemic evaluation, expectations and goals. It is said by several authors that addressing the emotional messages or miscues of the patient's face yields a greater patient satisfaction. So one must aim at reducing the negative attributes of looking tired, sad, saggy, or angry, and try to enhance the positive attributes towards making one attractive, young, more contoured, and more feminine or masculine. Now, photographic documentation as a part of the aesthetic evaluation is very important, both pre-operatively and post-operatively. One can review the photographs of the patients at a younger age, and that will help in identifying the targets. Now, psychological assessment also is extremely imperative because it helps in revealing unrealistic, manipulative, unstable, or even at times certain hostile patients, the results for whom could be unpredictable and their response would be not something that we would be expecting. After this, we must undergo a detailed ophthalmic examination along with a detailed facial examination. The face must always be considered both as a single unit as well as having several components. The periorbital region provides for key features of the face, and eye contact naturally draws attention towards it. Patient history. So among the relevant patient history, we must rule out the presence of thyroid eye disease, myasthenia gravis. We must also conduct a systemic evaluation to establish surgical candidacy, any medications the patient is on, prior refractive procedures to avoid ocular surface damage, prior aesthetic surgical and non-surgical procedures. Amongst the ophthalmic examination, visual acuity, ocular motility, dry eye syndrome, and tear drainage system malfunctions, if any, must be ruled out. Now, we divide the face into three segments, the first being the orbitoskeleton and the globe. The relationship of the globe to the orbitoskeleton is extremely crucial. Facial bones form the framework and the base of attachments for the ligaments and the muscles that define the face. Mid-face comprises of zygoma laterally and maxilla medially. A prominent malar eminence is considered youthful. Aging is associated with resorption of infraorbital rim, leading to malar hypoplasia. Here, what you can see is that when you drop a line from the supraorbital rim to the infraorbital rim, it creates a vector. It's called a positive vector if the cornea is posterior to this line. And with aging, one goes from being positive to a negative vector, wherein the cornea is anterior to this line. Considering the exophthalmos and inophthalmos, one must know that exophthalmos may exacerbate lid retraction to produce a surprised look, and proptosis also increases the risk of post-operative eyelid malposition, while in case of inophthalmos, it may produce pseudotosis and may also cause superior sulcus hollowing, which gives a tired and aged look. The anterior globe prominence can be measured using a Hertel's exophthalmometer. This also aids in surgical planning, as a tailored approach towards the positioning of lateral canthus can be sought after in a lower lid blepharoplasty.
Slides, yeah, it's moving, yeah.
Yes, so moving on to the forehead and the upper eyelid complex, these are some of the important surface landmarks of the forehead, brow, and the upper eyelid complex. The parameters in here to be assessed include the sling, rhytids, brows, and eyelids. In case of a forehead, macroscopically, one must assess the shape, hairline, hair quality. Receding hairline in male pattern baldness can benefit from pretracheal incisions. In case of eyebrow position, Typically, in a male eyebrow, it is flat, and for a female, it is arched. We must focus on eyebrow symmetry or lack thereof, along with brow-ptosis, which could be as a result of the downward gravitational pull and aging, along with soft tissue laxity. Additionally, frontalis overaction leads to prominent horizontal forehead furrows. In this lady, we'll be able to comment regarding the rhytids. The rhytids are associated with underlying facial muscle contracture. We can see that the horizontal forehead furrows are formed as a result of the action of vertically oriented frontalis. The vertical lines between the brows are as a result of corrugator supercilii action. Horizontal nasal dorsum rhytids, or the bunny lines, are as a result of the action of procerus. The crow's feet are as a result of the action of the Orbicularis Oculi. In this video, we can see the eliciting of the dynamic rhytids, and these dynamic rhytids are known to respond favorably to muscle weakening procedures such as chemodenervation using Botox. Upper eyelids, droopy, wrinkled, or tired. Now, upper eyelids independently and profoundly impact the overall facial appearance and expression. So the appearance of upper eyelid as droopy, wrinkled, or hooded can diminish the prior youthful appearance. Upper eyelid dermatochalasis primary is as a result of true age-related excess of eyelid skin. Secondary, as a result of excess skin from sagging of brows. One must also remember that loss of integrity of the orbital septum leads to prominent eyebrow fat pads and displacement of orbital portion of the lacrimal gland, which can lead to puffy lids. Blepharoptosis evaluation in primary case with frontalis relaxed and brow in fixed position is absolutely essential as it alters the surgical planning. One must also note asymmetric lid creases, if any, because it may be indicative of levator dehiscence and will need LPS reinsertion. Now coming on to lower eyelid and mid-face complex. In this gentleman, one can see that there are severe eyelid bags. Now going on to the anatomy, we can see that this is the Orbicularis Oculi. And these are the surgical landmarks: the lateral canthal tendon, the medial canthal tendon, the tarsal plate, and the orbital retaining ligament. Now with age, we can see that orbital fat herniation is noted. Now orbital fat herniation may contribute to aging face, orbital septal weakening, orbicularis atrophy, supporting ligament laxity combined inside the orbital fat protrusion. Herein, examination in the upper gaze may assist in identifying problematic fat compartments. The lower eyelid and mid-face continuum in youth exhibits single convexity on lateral view. With age, convexity-concavity convexity develops as mid-face separates from the lower lid at the level of the orbital rim. Volume depletion and weakened mid-facial soft tissue support leads to lid-cheek junction contour irregularities such as malar mounds and festoons. We must also evaluate for eyelid laxity. For significant eyelid laxity may be an indication for lateral canthal anchoring to avoid lower lid malposition, lag of thalamus, and palpebral fissure deformities associated with periorbital procedures. To summarize, the critical aesthetic assessment of the periorbital face includes A. The knowledge of periocular and ophthalmic anatomy. B. Understanding of morphological changes associated with age, sex, and race. We must consider the face to be divided into three separate segments such as the orbitoskeleton and globe, forehead and upper lid complex, and lower lid and mid-face complex, because of which we'll
I think
Yeah.
I think we lost her, but I think, yeah, that's fine because she could complete her talk. So thank you, Vatsalya, for, a very informative session on how to go about the tell and tale signs of facial aging and what you should consider before we, take the patient for a treatment. And as I mentioned, it's very, very important to understand the background from where the patient is coming, the expectations, the lifestyle, in addition to what we see anatomically on the face.